All right. Good evening, everyone, and welcome to this ASRA non-CME industry education webinar brought to you tonight by Pajunk Medical and ASRA. And so thank you very much to both of those entities for bringing us together tonight. My name is Jeff Gadsden. I'm going to be one of the hosts tonight. With me is a friend, Maggie Holtz. I'm from Duke University, and Maggie is the medical director of regional anesthesia at the Wellstar Health System in Atlanta. Now, I'm going to, that's us. and we're really excited about hips. We do, both of us do quite a bit of orthopedic anesthesia, and a part and parcel with that is taking care of patients with hip arthroplasty, hip fracture repair, and hip arthroscopy. And so I'm really keen to hear about Maggie's experience and also get your experiences. So please use the chat or the Q&A feature in the Zoom throughout the presentation. And we're going to save lots of room at the end for questions. Are we good with that screen? I think I'm going to just take over the sharing. Okay. All right. So we've titled this Hips Don't Lie, The Truth About PENG and Other Blocks for Hip Surgery. And we're going to explore some of those themes in the next 45 minutes or so. So these are our disclosures. Both of us actually have consulting relationships with both Pajunk Medical and Fascia Biosciences. And it's interesting how blocks and neural blockade for hip surgery has changed over years. I mean, I remember a time when we didn't do a whole lot, and we have eventually added different blocks into that recipe. And part of the way we wanted to think about it is what are the nerves and the fibers that we're trying to block? And so a simple conceptual drawing of how the proximal femur and hip joint are innervated is like what you see here. So you have a lot of femoral on the left-hand side, that's the anterior side, and the posterior side's on the right. So a lot of femoral innervation, a lot of obturator innervation. So that's that medial part of that proximal femur and the head of the femur and the neck. And then a chunk of the greater trochanter and the posterior part of the femur is served by the sacral plexus. And so that has always led to challenges in providing outstanding pain control for hip-related pain, because you've got not just one plexus, but two plexi, so the lumbar plexus and the sacral plexus. And so there's different solutions to that. And we do end up asking, like, which block might be good. So we have the epidural, which we used to do a lot of. Of course, epidurals are fantastic. Patient's not going to feel their hip afterwards, but they're not going to also walk all that much. We did a lot of lumbar plexus blocks at one point, and that's a great block for hip surgery, because you're not just getting the femoral nerve, but you're getting the obturator, the lateral femoral cutaneous for that skin incision, and then a few others as well. So that's a fantastic block for hip surgery, but again, is going to lead to some degree of motor weakness usually. Fascia iliaca ended up becoming one of the heavy hitters in recent years for us at my surgery at our hospital. It's, again, sort of a modified approach to the lumbar plexus. You're hoping to get the femoral obturator and the lateral femoral cutaneous in an anterior approach to that lumbar plexus. And we'll talk a bit more about that in detail in a second. And then some people use femoral blocks as well, and for hip surgery. And there's some concern or questions or controversy maybe about what fibers are we getting out of the femoral nerve at that level, and have we in fact got the ones that we care about for hip surgery? And Maggie and I will talk a bit more about that in the next few minutes. But one of the problems and controversies and considerations, rather, I guess it was a better word for it, about the choices related to these blocks is pain control versus mobility. So we can do an epidural, we can do a lumbar plexus, we can do a fascia iliaca or a femoral and get decent pain control, but are those patients going to walk afterwards or be able to, or be safe ambulating? And of course, we are doing more and more outpatient hip surgery, and not just that, but we have patients that have had hip fractures who our surgeons are now expecting to walk the same day, which was not a thing when I was just learning how to do all this stuff several years ago. So that is the big crux of our problem: ambulation, motor power versus high quality analgesia. And so I thought we'd start this off by talking about the fascia iliaca plane block, because I think for a lot of us, and I think for Maggie and I, this was until very recently the block of choice. So I'll turn it over to Maggie to give her thoughts on the fascia iliaca.
Great, thanks, Jeff. Hi everyone. It's really wonderful to be here, and thank you to ASRA and to PENG for hosting this. So yeah, the fascia iliaca plane block, an oldie but goodie. It's been around for a while. It started off as a landmark-based block, and it's sort of seen a resurgence because we gave it a makeover. We changed the point of insertion to superior to the inguinal ligament, and I think it gives us better pain control. In the previous slide, you saw kind of what we used to do. We used to find two bony landmarks, trisect it, pick a point inferior to the inguinal ligament, dump as much local anesthetic as was available in the pharmacy that day after we thought we felt two pops, and hope that we got some sort of anesthesia of a nerve. You can see why it really wasn't that effective. So what we've done now is we've sort of adjusted this block. You can go to the next slide. Sorry, Jeff has control of the screen. So what is the
core control?
It's basically a sheet of fascia, and it covers the iliopsoas muscle, both superior and inferior to the ligament, and it kind of pexes the lumbar plexus onto those muscles. And the nerves we're interested in blocking are the lateral femoral cutaneous nerve, or LFCN, the femoral nerve, and the obturator nerve. Now, you can see when we used to do these blocks infrainguinally, it was a big ask, regardless of how much volume you used, to get that local anesthetic to spread both sort of laterally medially to get those nerves, or over top that pinch point of the inguinal ligament. And we'll see this when we look at the ultrasound, that true pinch point, really preventing that local anesthetic from spreading over top and spilling into the bowl of the pelvis, which is really where we want it to go. Because once it spills into there, we really have this like marinating of all three of those nerves that we want to get. Also, the articular branches of the obturator and femoral nerves come out fairly proximally. And so anything infrainguinally is really not going to get that. And that's why we saw when we initially did this technique inferior to the inguinal ligament, it was really a kind of a poor man's femoral block. We occasionally might have gotten the lateral cutaneous nerve. We almost never got the obturator. But now with moving it just superior to the inguinal ligament and really getting that local anesthetic to travel underneath that fascia iliaca and bathing those nerves, we really get a much better block. All right, so Jeff showed this slide. This is the innervation to the proximal femur. And you can see that really all three of those nerves do matter. So while most of it, anteriorly at least, is controlled by the femoral nerve, there is a significant contribution from the obturator nerve. Also, the LFCN is really important for that incisional pain. So really a nice little adjunct. So the probe position for a sci-fi block, you palpate the ASIS, or you can see it on your ultrasound machine, and you place the probe just medially to it in the parasagittal orientation. You slide inferior just a little bit, so the probe is lying essentially right over the inguinal ligament. Your needle trajectory comes just inferior to the probe and goes superiorly. So you really want your needle to come in very shallowly and kind of penetrate the fascia iliaca, depositing local underneath the fascia iliaca, so it bathes those nerves superior to the inguinal ligament and allows that local just to sort of spill into that pelvic bowl. Another important landmark that you see on ultrasound, the deep circumflex iliac artery. So this is a branch of the femoral artery that comes off proximal to the inguinal ligament, and it lies on top of the fascia iliaca. So it's another thing that you can use to sort of confirm that you're in the right plane. Okay, so this is what it looks like on ultrasound. To the left of the screen is cephalad, or as Jeff would say, cephalad. To the right of the screen is caudad. And you see this nice bony landmark. That's the pelvic brim. You have this pinch point in the center. That's where your inguinal ligament is. And so again, that shows you how almost impossible it was when we were infrainguinal to have that local anesthetic over top of the pelvic brim and get to really where we needed it to be. You also see, your iliopsoas muscle on both sides, and you see that bright white fascia iliaca. You also see cephalad, a bit of the abdominal wall muscles there. You see one or two here, branches of the deep circumflex iliac artery on top of the fascia iliaca. And again, these are all important parts. And so this is a video showing the needle coming in. And you really want to come into sort of the corner of those abdominal wall muscles pretty shallowly. So you can sort of just skim into that fascia iliaca. This is coming in a little bit deep, and it's going to show you an incorrect injection first. You're aiming to get into that fascial plane, but what you see is actually an intramuscular injection. So it just kind of looks like mush, right? You don't really see that nice unzippering of that plane. You don't see that local anesthetic traveling down that plane. So let's start over. Pull the needle back. Let's start over. Once we come in a little bit more shallow, you can pop correctly into that fascial plane, and you'll really see the difference here. But I think it's important learning what the incorrect pattern looks like, because we see that a lot. A lot of times you're not in the right to begin with. All right, there you go. So there's the real unzippering. And you can see that deep circumflex iliac artery pushing up. You can see the iliacus muscle pushing down, and you can see that nice spread of that local anesthetic. And so that's what you want to see.
That's beautiful. Ooh, that warms my heart to see that unzippering.
And you can see that the arteries are on top. So if you see the arteries getting pushed down, you're probably on top of fascia iliaca. You really want to see them push up, and that iliacus.
Yeah, that's a great landmark. I do appreciate that. When I see sometimes the first injection is in local tracts up and over, you're not in the right plane, because it looks easy here, but I think you'll agree, Maggie, right? Like in a lot of elderly people where the fascia is not quite so apparent, they're like, am I in the right plane or am I not? Sometimes you need to
That's exactly why I like it better.
some
Yeah,
tests.
the elderly patients, they lose that integrity of those fascial planes, and it's not as easy to see it and identify it. It's not as easy to get into it. So this just shows that volume really is key here. This is a volume block. In order to get the best bang for your buck and get all three of those nerves, you really do need considerable volume. 40 cc's really is the name of the game here if I dilute local anesthetic. Next slide.
Yeah, and we use 40 for this too. We usually use 0.2% ropivacaine, but sometimes, have you found you've had motor block with this? With 0.2%? Yeah, us too. It doesn't happen in everyone, but in the ones that when we first started doing our ambulatory HIP program, we were doing sci-fi, and we decided to ramp it down a bit to like 0.15 or in some cases 0.1, just to try to get that sensory block without that motor block. Because part of this, I mean, part of the mark of success is you are getting a femoral nerve block, right? So.
Yeah, and that's intended, right? That's one of the nerves you're trying to block. And we weren't brave enough to do that for our same-day total joints. We moved straight from infiltration to PENG because any sort of motor weakness is unacceptable in an ambulatory patient. So yeah. That's definitely a consideration with this block, and might limit it for what you're trying to use it for. But this just shows, with 40 cc's, you really do get that nice spread to all of these nerves. So you get over 90% of the time you'll get femoral and LFCN nerve. And early on, even about 75% of that obturator. So you can really see the bang for your buck you get with the full 40 cc's of volume.
Yeah. There was some controversy about that obturator and whether it actually got it, but I think that it's at 40 cc's, right? It spreads sort of underneath that psoas muscle a little bit and gets to those fibers. So.
All right, so some tips. Palpate the anterior superior iliac spine. You can usually feel this, and even in our heavier patients, or you can see it on ultrasound. It's a big, bright white bone. And then just plop the probe immediately medial to it, slide 3 to 4 centimeters inferior to get the ideal view. That's a lot easier to find bones first, something you can recognize, than to try to find these sort of nuanced fascial planes that might be a little bit deceiving, especially in our elderly or obese populations.
Bones don't lie.
Don't lie.
No.
You heard it here first. Shallow trajectory is helpful for a couple of reasons. One is we saw that when the needle came in steeper, it was more likely to get intramuscular. It's harder to sort of catch that plane because you don't have a great landing point. If you come in more shallow, it's easier to sort of fall into that plane. I do this when I'm doing tap blocks as well. I try to come in as shallow as possible, just to sort of skim into that fascia iliaca plane. Moreover, the more shallow you are with your needle and the less steep, the more echogenic it's going to appear because more of those ultrasound beams are getting back into your probe. So those 2 reasons. The needle tip must be cephalad to the pelvic brim to prevent spilling back down the thigh. Again, our whole goal is to push that local anesthetic superior to the inguinal ligament. You really don't want it falling back. That's not going to give you that great 3-in-1 block. You really want to push it over top and have it spill down into that bowl. Yeah, that's the pinch point that Jeff is pointing to right there.
Yeah. If you're caught out of this, it'll all just stay in the thigh and very little will get up into the where you need it. Okay, and here we are. The PENG block.
So PENG, kind of the new kid on the block, but it's really kind of taken the regional world by storm. It's kind of like the new it girl. Well, that and ESP, I guess. But PENG is short for Pericapsular Nerve Group block. It also happens to be the last name of Philip PENG, who described this block, so that's pretty cool.
I admire that move. What a good move.
I don't have a block named after me. You?
Not yet. No. You can work on it.
So here's the anatomy. So you can see the iliacus muscle and the psoas major muscle as it kind of courses over the pelvic brim and sort of inserts on the lesser trochanter. As you lay the patient supine and you remove these muscles, you see the bony landmarks that are very visible and very easily visible and identifiable on an ultrasound. So you can see the anterior superior iliac spine, which isn't labeled, but it's to the very, very right. The anterior inferior iliac spine, you see the superior pubic ramus, which is that sort of trough. The iliopubic eminence it's that next little hump there. And these are all, again, very identifiable on ultrasound. Okay, some other real estate in the area. You have your inguinal ligament in purple, and you have your femoral vessels and your femoral nerve there. And this is important because we do not want to target the femoral nerve. The whole point of doing this block is to just get the articular branches and not get a motor block. So fortunately, the femoral nerve is encapsulated and sort of protected in the fascia iliaca at this point. So as long as you are through that posterior border of the iliacus muscle and you don't do an intramuscular injection, you really should be clear.
So what are the nerves that are? Sorry, go ahead.
I was going to say the psoas tendon is another really important landmark that you'll be able to see on ultrasound, and that's kind of where we determine where to aim our needle. What was your question?
Oh, I was going to ask what the nerves are that you are after here.
Yeah. So, well, thanks for asking, Jeff. The really the articular branches of the femoral nerve, the obturator nerve, and the accessory obturator nerve. And these all come over top the superior pubic ramus and innervate the anterior joint capsule. And studies have shown that there's a very, very high concentration of nociceptors in the anterior joint capsule. And that's why this block works so well. A lot of the pain from many different kinds of hip surgeries is really that capsular pain, not unlike why we target the IPAC for knees, because a lot of that posterior pain is really posterior capsular pain. Same thing for hips. So that's kind of the premise of why this block works so well.
Yeah, I saw that study. It's from a while back, right? It's one of the anatomic studies showing that anterior medial capsule, where all these nerves kind of converge, is the most richly innervated part of that hip. And that, the posterior part doesn't have all that much innervation. It's mostly anterior and anterior medial.
And there's your obturator again. It is an important nerve.
Yeah.
So here's your trajectory of your needle. So it comes in lateral to medial, and you hit bone. This is the beautiful thing about this block. You have a nice, easy, bony backstop. Can't go any further. You want to aim to be lateral to the psoas tendon or sort of snake underneath it. And once you inject your local anesthetic, it just sort of layers along that bone and anesthetizes all of those articular branches as they emerge from the pelvis.
And you and I have done some cadaver studies looking at the spread here, right? And it's amazing how a little bit will go up sometimes into the pelvis, but then a lot of it will just spread exactly like this figure is. It just coats that entire capsule.
Yeah, it's cool.
20 mils of dye.
Medially to the psoas tendon, we didn't get as great of a block. And I think we were missing some of those femoral articular branches.
And I also remember, sometimes what I experience with PENG, and tell me if you feel the same way, is when I'm too close to that tendon, I think I'm actually inside the tendon, and that's impossible to inject. And so I have to pull back a little bit. But if you recall, on one of those injections in the cadaver, we had an intratendon injection, and it was just the tendon sheath that was blue, none of the nerves in the capsule. So I actually don't try to get too close to the tendon these days. I'll go just out, sort of where this arrow is pointing. How about you?
Yeah, I mean, I just go lateral to it, and I watch the local spread under it. But yeah, because what we saw was like a sausage casing. That was where all the local or the dye stayed. So obviously none of it was getting to the articular branches. This is a sausage block, but none of it was getting to articular branches, and also possibly doing some damage to that tendon sheath as well.
Yeah, fair enough. Yeah.
So when you put your probe on, it's sort of in line with the inguinal ligament. And if you use a curvilinear probe, you get a nice wide view of this brim. This is what you see. So left is medial, you see your femoral vessels, your femoral nerve. You see these bony structures, the IPE, the trough of Schwartz. He was in our cadaver labs. We're trying to make that happen. The AIIS. And you see that bright white sort of hyperechoic psoas tendon. It's usually very, very evident. Your big iliacus muscle. And again, you'll see the more people you scan, this is a very broad sort of rim. Sometimes it's a little more angulated. We have another slide in a bit that shows a little bit of a different type of anatomy, but essentially this is what you want to see. And your needle is going to come in lateral to medial. So probe position here in line with the inguinal ligament, needles in plane, lateral to medial. You can see the needle coming in and landing just lateral to the psoas tendon there. And you can see a test injection. Beautiful. So what you're seeing there is a couple things. You're seeing that psoas tendon really lift up and that iliopsoas muscle lift up. And then you're just seeing this layering of that local anesthetic all along that pelvic brim. So that's different from what you see when you do an intramuscular injection. Again, just like the Fascia Iliaca block that we showed you, an intramuscular injection doesn't look that pretty. It's not as like, how would you describe it? It's like, blah, it's like mush.
How can I top moi? In terms of its sonographic appearance, I like the mush. You see those muscle fibers expanding, but this is a really important technical point, right? Because we have had and heard of patients getting a femoral block after a PENG block, and so I think one of the things is make sure you're underneath that epimysium of the iliopsoas muscle. And sometimes I'll bring the needle down, hit the bone, do my test injection, and I'll see backward spread up into the muscle. And so it takes another little kind of like twizzle of the needle to get through that. we can call it
Exactly.
the Holtz twizzle, and then you see that nice spread. Conversely, sometimes I put the needle into the periosteum and I'm like, I can't inject, and so you have to pull back very slightly, and then you get the nice spread.
Yeah, your nurses will definitely complain about having carpal tunnel with this one, especially in these, big young men who have a gigantic iliopsoas muscle. But I think those are all really important points. So I think we went over most of these. Curve transducer, you can do this with the linear, but the curve transducer gives you a very, very broad, wide view, and you can see all kind of the peaks and valleys. And we kind of talked about this, withdrawing the needle, but again, making sure that you're not intramuscular. You really have to get through that posterior border of the iliopsoas. That's so important. That's probably the one pitfall of this block that we do see.
Yeah.
And then again, the PENG just gets the articular branches. It does nothing for incisional pain. So we typically add an LFCN block, an extra 5 cc's, 3 to 5 cc's, to get that skin coverage. And so this is really the coverage pattern that you're going to see with the PENG. So really does a nice job of covering that capsular pain, does a nice job of targeting a femoral neck fracture, an intertroch fracture, but notice that it doesn't really spread any more distal to that. So things like subtroch fractures, or certainly femoral, more distal femoral fractures, will not be covered by a PENG block. So I think it's important to notice that and to take note of that when you're dealing with a hip fracture patient, because you might just get, hey, this patient has a hip fracture. Well, now you actually have to figure out where that fracture is to see if that PENG is an appropriate block for that patient. In the middle is showing the dermatomal coverage of the LFCN. It's a pretty broad coverage. We actually use this for both our anterior and posterior approaches to our total hips. We also add it to our arthroscopies, because even though some of the anterior ports are out of this coverage pattern, the lateral ports are there as well. And then importantly, no motor, as long as you don't do an intramuscular injection.
I'm gonna ask you some questions here while you're on the topic. So, you said you use the PENG for both posterior or lateral approaches and anterior approaches. Do you find them, Maggie, useful for both?
I do, for total hips.
Yeah.
I do.
That's the question.
Yeah. So, our we never went through the Fascia Iliaca, the dilute Fascia Iliaca for total hips. We went straight from surgeon infiltration. It's like, I'm ashamed to say that as a regional anesthesiologist, straight to PENG. I know. Right. Straight to PENG. So, we started doing outpatient total joints, I believe, in 2015. And it was like, there was no room for error as far as knocking out the quad. And so if I wanted to get a block through to the surgeons, it could have a 0.0 risk of having a motor block. So we never did that intermediate Fascia Iliaca block that I think you did, and a lot of other folks did for hips. But we've seen, it was very easy to win over our surgeons with the PENG. They were very readily impressed, and it was a much quicker transition to letting us take over the infiltration than when we started doing the knee blocks and took over that infiltration from them. So pretty impressed.
That's great. I'm gonna ask one more question since we're on this slide, but I'll save some of the other questions for later. But Corey Lake is asking, since adding LFCN to my PENG blocks, I've had inconsistent skin coverage. Any pointers for how to get a good LFCN block?
I think the way that I find it is I sort of have the probe just sort of, this way, and I scan straight lateral, and I find the femoral nerve, the sartorius, and then it's literally just in that little fat pad right in between sartorius and tensor fascia lata. I find that I can actually see it better, more distally, as it sort of pops over the sartorius, but I get a better block if I follow it superiorly. So I really try to find it and then follow it and block it a little bit more proximally. I think if you're getting it too distally, it's all sort of branched out, and I don't feel like you get as good of a block.
Yeah, I agree. I go as high as I can. And so it's just squished between sartorius and the overlying inguinal ligament. Cool. one of the things I think you alluded to this earlier is how easy the PENG is. And I think that's lost sometimes in the discussion about the comparison. And so we talked about the fascia sometimes being a bit difficult to appreciate in some patients with the sci-fi. But tell me what you think about this idea, how easy PENG is compared to sci-fi.
It's so easy that I'm teaching our ER physicians how to do this. A little dig. But no, it is easy. And I think that that's the name of the game. We now use PENG for most all of our hip surgeries because it's easy to learn, it's easy to do, it's easy to get a good result from doing it, and it's easy to teach. And, I'm in private practice. We don't have an army of regional fellowship trained folks. We have a group of people who, yeah, they think regional's cool, but, the easier the block is, the more likely I am to get them to want to do it and to do it correctly. And seeing a bone, you can't miss it. It doesn't matter if they're obese. It doesn't matter, if they're old. You're still going to have the bone. So I find the sci-fi to be a very frustrating block sometimes. Even if I can see the fascial plane, oftentimes I don't feel like I can get in it on the first, second, or even third try. It's just a lot of finagling. What's been your
Oh, totally. Anytime I have to teach a block where hitting a bone is the endpoint, super easy. Now, Todd Stevens is asking a good question here. Tips for getting local to spread medially under the iliopsoas tendon. So he's saying, I often get the local staying lateral and nurses complain about difficulty injecting. Seems maybe if he moves a bit cephalad farther from the capsule, he gets success. Do you find the same thing?
Yeah, I do. I definitely, I look for the femoral head first, and then I move cephalad to sort of see this picture that we're seeing. But I think seeing that lateral spread, I oftentimes feel like I'm intramuscular when I'm just seeing that backtrack. And so I'll try to corkscrew it a little bit more, try to slide my needle a little bit more underneath that psoas tendon, being careful not to puncture it. And then I often see more of that medial spread. How about you?
It takes a bit of working with the needle a bit to sort of, again, almost, if I don't see good lifting up of that psoas tendon. And remember, this is a very tight space, right? Like you got muscle tendon jammed between the pelvis and the inguinal ligament, which are two inflexible structures. So there's you don't get the same opening up of the plane with the PENG that you do with the sci-fi, but you try to see that medial spread as best you can. Sometimes a little digging with a needle and some kind of test injections can help with that.
It's not as satisfying. It's like doing a QL block versus doing, like a TAP or ESP. You don't get quite that satisfying, like you said, opening. But I think that layering as well. I look for the lifting and then the layering. Yeah.
I want to just share a couple of studies here as well, because it's interesting to see how these blocks stack up when compared against other things. And this is one of them. I apologize, I've advanced the slide and I can't go back for some reason. But they looked at PENG versus no block and looked at a bunch of different outcomes and found that the primary outcome was quality of recovery scores at 24 and 48 hours, and found that there was a difference at both time points, 24 and 48 hours, for that combined index of quality of recovery compared to no block. And that's great. I like that. That tells me that there's something happening with the PENG. It's not just Emperor's New Clothes. And this is another study in an anesthesia journal looked at, again, PENG versus sham. Some of these early studies looking at, does the block do anything versus an active comparator. So they used 20 mils of 0.375 or pivocaine in the PENG versus a sham block. We actually didn't talk too much about local volumes. Are you using 20 or 15, or what are you?
Yeah, we're using 20 in the PENG, and then adding 5 for the LFCN.
Yeah, so 25 total.
Yeah.
So this group compared the PENG with local versus a sham, but both groups also got 20 mils of that same concentration as local infiltration. So it was like an add-on to the typical surgical joint infiltration. And what they were able to see was that pain scores at 12 hours were different. The opioid consumption was significantly decreased, and the mobility time to first walk was also improved with the PENG, which is interesting because you've got the local infiltration there as a baseline, and you're adding this, which tells me that, to your point earlier, local infiltration alone can be inconsistent and not a total solution all the time. So if you add a precise, image-guided, consistent application of local anesthetic in the right place every single time, you get additional benefit, if not better results altogether. Did these surprise you at all, or?
No, and I think that's the whole point of why we've taken over surgeon infiltration. Yes, I spent the better part of the last decade of my career trying to kill surgeon infiltration, but it's for a good cause, for the patients. Because we can see those, we know exactly where those nerves live. We can see it, so we can precisely target it. We don't waste any local getting there. We do it exactly where it needs to be. And we can be more consistent with it. And I think you can have a really meticulous infiltrator and they can have good outcomes, but it's still not as consistent because it's a blind injection. Yeah.
Now, this is a study done fairly recently, looking now at PENG with 20 mils of 0.5% versus sci-fi, same milligram dosage, but 0.25%, 40 mils, because we need a bit more volume in the sci-fi. And this was interesting to me because I was a sci-fi person, and we were looking for an alternative to move to with that motor block problem that we were seeing. And I was reassured to see the results of this study because they showed no difference in static pain intensity or opioid use for 48 hours. So that was great. And that's been our experience too. I mean, when we switched from the sci-fi to the PENG, honestly, our surgeons didn't even know. And neither did the physical therapists or the post-op nurses. They were like, okay, the same old patients getting the same old blocks. And so that was a win for us because, again, easier block to do in many patients, especially I think the elderly. So, and then there's this one too. So this one was also done very recently, and again compared PENG versus sci-fi. So 0.2% ropivacaine, 20 for the PENG versus a slightly larger volume for the sci-fi, and same thing, no difference in pain intensity or opioid use for the first 48 hours. That's good. That to me shows we've got, you can choose whichever one you want, seems to do a good job. This one, they actually looked at quadriceps power and didn't find a difference, which is interesting. So to me, that says that rings true, because it wasn't everybody that had a motor block with the 0.2%. It was a smaller cohort, but I guess if they found no difference in quadriceps power overall, that's a good thing. Does this surprise you at all, or make sense? Or
it does, and I think there's been other studies that have shown a difference in quad strength, PENG versus sci-fi, where the outperformed the sci-fi in the quad strength, and maybe you're going to show that. And I also think it's important to note that any patient who has surgery, who has nerves cut on, they're probably not going to have a totally normal motor exam immediately post-op. So that's another thing to sort of consider as well.
It is hard to evaluate motor function after total joint arthroplasty, right? Because they get the reflex inhibition of the muscle fibers and the spasm sometimes, and just pain-related inability to move. So this is an interesting study that came out, and it was a little bit provocative because it compared a PENG block, so 20 mils of 0.5%. And to me, that's a decent concentration. I tend to use a lower concentration because I don't want to get that motor block with the femoral versus a sham. And so again, back to looking at, does the PENG do anything? And in contrast to some of the other studies, this one showed no difference in pain or opioid use. So no matter if you got a PENG or the sham, and this kind of threw a bucket of cold water on PENG enthusiasts a little bit with the headline from the abstract. But what you had to understand about the methodology was every patient also got 30 mils of up to 30 mils of quarter percent bupivacaine with local infiltration. So maybe it's not the same as saying a PENG is no different than a sham. Maybe that's true if you also put 30 mils of quarter percent BP into that joint as well. So I think that's the grain of salt that I take with this one. How about you?
Yeah, same. We still do PENGs for arthroscopies, and we moved from lumbar plexus to PENGs in that subgroup, and we've seen great results. Again, I think it's important to say that all these fascial plane blocks, and I consider both these fascial plane blocks, we use a more dilute local anesthetic. They are meant to be used on the background of a robust multimodal protocol. There's a lot of spasm pain in these hip arthroscopies. So we use a lot of, things like methocarbamol, things like that. There was a question in the Q&A about, are these anesthetic blocks or analgesic blocks? And I want to be clear that these are analgesic blocks. These are not full-on anesthetic blocks. You can't, cut on a patient just with a PENG block. Without.
That's a good point. You might be able to get away with doing that with a sci-fi and a sacral plexus block or something like that, and get a quasi-surgical anesthesia, but a PENG is simply an analgesic block. So I wanted to ask you about the spasm issue that you talked about. So did you ever do sci-fi, and did you find, or femoral for hip fracture or hip replacement? Yeah. And do you find a difference in the incidence of spasm afterwards and pain related to spasm because you're doing a PENG that doesn't get the muscle fibers?
I absolutely do. And it's funny you asked that because, we used to do both femoral and fascia iliaca for hip fractures. And when we moved to the PENG, I wasn't as pleased with it, especially pre-op, those patients who, you get to them early, they're not having surgery for a bit of time. I just felt like the PENG wasn't as impressive to me for their analgesia as it was in the other things like total hips or hip arthroscopies. And I think a lot of that early pain is that spasm pain. And so what we do now is when we first see the patient, we actually will do a PENG with a longer acting local anesthetic, adjuvants, catheter, whatever, to extend that block post-op. And we'll also add a single shot femoral block, no adjuvants or nothing, just to kind of like give them that extra oomph for that first sort of preoperative time.
That's really interesting. There's the question in the here, did we see, where was it? Somebody asked, do you ever do sci-fi and PENG, sort of belt and suspenders? And it sounds like you do femoral and PENG sometimes to address that problem. What's interesting. So you just using lidocaine or bupivacaine or something just to.
But like 15 C's, 10 to 15 cc's of 0.5% something. And just to buy you that time, because the earliest those patients are going to ambulate is if they have surgery. Let's say we don't get them until immediately pre-op, and they're the first case of the day. They're not the earliest they would want to ambulate. The surgeons would want to ambulate them is later on that evening. So my femoral block is going to be worn off anyways. And there doesn't seem to be the pressure or the embarrassment of, oh my gosh, my patient has to have a neomobilizer, as in the total joint population. There's a little bit more leeway for that. Yeah. The femoral and the hip fracture patients. And then typically our patients don't even ambulate till the next day. So it's not really an issue. So I have that femoral block to sort of target that intense pain, that muscle spasm, and then that wears off, the patients can ambulate. The PENG kind of covers more of that post-operative pain. But that's something new we've done probably just in the past month, because I was just trying to, just find sort of that Goldilocks combination for hip fractures. I wasn't just super stoked about only the PENG. But I talked on such a big talk that I didn't want to go back, to the Fascia Iliaca. So
No,
this is
for
my
sure. For sure. That's interesting. All right. Question. What complications have you seen with PENG in your practice? Besides motor block, we'll say motor block is a known complication. I think it's related to volume or concentration or inattention to your needle to position. So we'll take that off the table. Any other complications that you've seen?
Really, we haven't. That was the one I was going to add. I had one patient who had an aberrant femoral nerve intramuscularly, and she did get a motor block, and I went to scan her afterwards, and enough of it must have just sort of like seeped into the muscle, because she had great pain control, but she did have, a short-term motor block. That's really the only thing that I've seen, with the PENG.
Yeah, no, and that's something to recommend it, right? Because it's there's not a lot of vessels that you're going to encounter, unlike the deep circumflex iliac artery, which I've seen someone hit with a needle, and it's a decent sized artery. So not a lot of tiger territory to deal with. Couple of questions about what if there's a fracture in that area? Do you ever see blood or in that plane that interferes with the block? I've never seen that. Have you seen that?
I've seen blood. I have seen, the bony landmarks might look a little different, especially if, you have a lot of fracture around there, but I've never seen blood or aspirated blood in there.
Yeah. So here's a question from Henry Das. For hip fractures coming into the ED, whether you're an emergency medicine physician or an anesthesiologist, and just to be clear, we've got lots of emergency medicine physicians that are doing amazing things with blocks in both our institution and many others. So I know Maggie was poking a little bit of fun there earlier, but what do you think is the right solution for that? Someone comes in and that your ER to OR time is going to be about 24 hours, let's say.
Yeah.
What do you like?
Just to be clear, I will always poke more fun at surgeons than ER docs. So.
Oh no, I've heard you poke more fun at surgeons. Yeah.
So yeah,
we'll offend everybody here.
Right. That's a great question, and it's something that we are trying to deal with right now. Again, I'm in private practice. We don't have a bunch of residents. We have a skeletal crew at night and the weekends. So what is the best solution? Historically, we were getting those hip fracture patients immediately before they came to the OR, and our door to OR time is about 27 hours. So sometimes we wouldn't even get them. They'd sit there on opioids for the first hour or day. They built a brand new tower for the ER, and it's literally like across an interstate from our OR. So it's just too far. Not deploy there. It's just unsafe for us to leave that, go so far away from the OR. And so our solution has been to teach the ED physicians how to do a block. Now, this is where we were talking about the ease of the PENG. I wanted to choose one block. I didn't want to open Pandora's box and say, well, here, use this, do that, do that, do that. Here's one block. It's easy, it's safe, it's teachable, it's, efficacious. And so I've taught them the PENG block, and we've had a couple workshops, and right now we're working on building privileges and their epic record and, all those sorts of things. But that's what we're working towards, so that if a patient comes with an isolated hip fracture, they can take care of that block as soon as they come in. Now, we did kind of put the caveat, if it's a polytrauma patient, they have a hip fracture, but also fractured ribs, a broken pelvis, a femur, then we've got to get involved, because we've got to make sure that we're dividing the local appropriately. But for those isolated hip fractures, I think that the ER physicians, they do a lot of POCUS. They're very adept at ultrasound, scanning. And I feel that that's the best option in our practice, where we don't have the support staff, like you might have, in academics. What are your thoughts on that?
Yeah, no, I like the PENG for all those reasons. I think when there's the spasm issue, I like your idea of adding a little bit of femoral on top of that. I think doing a fascia iliaca is hard in a 90-year-old. Questions about infiltration. It sounds like both of us are doing just blocks, no local infiltration by the surgeon. Concentration, I like to keep it low, 0.2%. something like that. Sometimes we'll add adjuvants to extend that duration. We've used dexamethasone there before. Pre-op or post-op better, typically pre-op, because as soon as they get into that plane, they're going to distort everything. And so if you can get that block in ahead of time, and that'll work. Question about catheters. We've done PENG catheters too, and it's a little bit they're not too bad. So you, again, hit the bone, expand that space, thread the catheter in a little bit. Or if you're using the catheter over needle set, you can just sort of hit it. And then as you're pulling the needle out, just make sure you're pushing that catheter a little bit to make sure it's staying in that plane. And they do very well. We've done PENG alcohol ablations for palliative patients that aren't going to get surgery as well. And that they seem to do okay. Questions about can you do PENG in an anticoagulated patient? Yeah. No, there's no real big vessel to hurt there. So I think it's another thing to recommend. And again, getting back to the safety issue.
Yeah, cut on a patient with a scalpel, I'll put a little needle in them. So that's kind of how I feel about most of those, fascial plane blocks.
Yeah. How about infection risk? Someone's asking about when you're so close to the joint with your needle, do you need to worry about infection of a new hip?
So this is why we do all of our blocks preoperatively, obviously. I won't do a PENG if I have a known infected hip that the surgeon's going to, remove the hardware, put it in a spacer, do an IND, those sorts of things. For the same reason, I don't feel comfortable doing genicular blocks on an infected knee. It's too close. Why? I don't want to put my needle into an infected space. So I won't do a PENG if it's a specifically infected hip that's going to have things removed and new things put in. But pretty much everything else I do. And we've been doing PENGs for 4 or 5 years and really haven't seen any infectious risk. I think, you have to be thoughtful about your sterile technique, really prepping the skin. Once we use sterile gel, once I find the spot, I'll take another swipe before I put my needle in. But just, common sense, things like that.
Yeah, same. When we're doing touching the bone near a joint, I want to be very sure I'm not leaving microbes behind. Yeah. This is a good question from Renee, asking about if you have a fracture there, and presumably the bone is now exposed to the inside of the cortex. Is there an increased risk of toxicity because you're putting local anesthetic there and it gets inside this very vascular medullary canal of the bone? I am unaware of any case reports related to that. Are you?
Yeah, I haven't heard it. No, I haven't. And I think, I think because we use such dilute concentrations of local anesthetic, we're not getting anywhere near that toxic dose. And you presume that not all of it is going to be, uptaken, but it's an interesting thought. To be honest, I hadn't even thought about it.
Yeah. Interesting. Experience with other adjuvants. Have you used other adjuvants to extend the duration of your blocks? Asks about dexamethasone, there's some about dexmedetomidine, catheters people are asking about, and then some have asked about liposomal. Any experience with any of those?
Yeah, pretty much with all of them. I think that, we do want to extend the duration. I don't know that there's the perfect one size fits all for that, but I think those are all viable options, and it depends on kind of the patient. It depends on what you have in your institution. And it also, especially for catheters, depends on the infrastructure that you have on your block surface. Heidi has given us some warning about time. I do want to comment something on something you said, Jeff, that was a question about surgeon infiltration. I think that, as we are doing these blocks, we are doing bigger volume blocks. I think it's really, really a good idea to pick one. So if the surgeon are going to infiltrate, they own it. Mm-hmm. If we're going to blocks, we own it. I don't share with the surgeons. Maybe that's why I didn't do so good in kindergarten. But I think for 2 reasons. One is the toxicity concern, and then 2 is kind of the blame game. So if you're sharing local, I'm doing a block, they're doing a block. If it works, great. Who needs, who does a great job? If it doesn't work, who needs to kind of work on their technique? And so that's why, total knees, total hips, and hip fractures, we've moved completely away from surgeon infiltration, and we really take over that block. And I think it's really improved sort of the safety of that process.
Yeah, totally. Other good questions here. QL block versus, we haven't talked about QL, but and I don't use QL for hips. Now, lots of people do, or some people do, I should say. And it kind of makes sense in the sense that you're getting probably L1, you know, at the very least, L2 probably in there. So some of those roots that are coming around and innervating the hip in sort of the iliac area, I think to my way of thinking, it's an indirect approach to where I want the local to go, whereas PENG is a much more targeted, I'm putting it on the capsule that's going to be operated on, compared to, and again, QL is not always an easy block to do in an obese patient. And here in the biscuit belt, a lot of our patients are getting hips that are not small. So finding that anterior QL plane in someone with a BMI of 40 is far more difficult than doing a PENG block in that same patient. Again, bones don't lie.
Agree.
So Matthew has a comment here. When I perform the PENG with a more cephalocaudate orientation with a steeper hill of the iliac crest, he notices the spread is very straightforward, especially when opening the plane with about 5 mils just lateral to the tendon and then moving underneath the tendon from there. Have you ever changed the orientation of your probe from that parallel to the bone orientation?
Not much. I mean, a little bit of adjustment, right? Because I feel like everybody's anatomy is a bit different. And so, adjusting the probe back and forth. But I've never, I don't think, done it like Matthew was describing.
Yeah. I think we have time for one more question. So let's just sum up, and I want you to give me the procedures that you think PENG does an outstanding job at versus sci-fi, and where you would see both of these fitting into contemporary regional anesthesia practice.
So I'm a PENG fan, just, I think that's very clear. But I think it works, it especially shines in total hip, either anterior or posterior, combined with the LFCN. I think it does an amazing job of getting that capsular coverage, and then the LFCN adding that incisional coverage. And I don't worry about the motor block. And even though there are some studies that show that there isn't a difference, and maybe they can, an intramuscular injection, if a patient has some sort of motor issue at the end, I can with confidence tell my surgeon, hey, it wasn't me. I did not block a motor nerve. Whereas if I was doing a sci-fi, I would have that concern. So I think that's where the PENG really shines. But I think, again, we've also seen a lot of use for it in hip arthroscopies and some hip fractures, especially for that post-operative period. Mm-hmm. How about you, Jeff?
I like PENG for hip fracture if it's a femoral neck fracture or intertroch. If it's below that, I'll flip back to a sci-fi. Like midshaft humeral or even subtroch, the PENG is just the capsular stuff, right? So it's not going to get those. And we have a big ortho-oncologic service as well. So when they're doing these big sort of resections and tumor excisions, I think a sci-fi is great. I mean, those patients aren't walking out the door the same day. So that's kind of my first question: is how important is ambulation in this patient? And if it is, and in a lot of our elective total hips, that is important. So they're going to get a PENG with the LFCN. If not, I think it's interesting to me to see that the pain experience is similar for hips, sci-fi versus PENG. It reassures me. I think the pain experience is better for a true femoral fracture in midshaft or proximal femoral. Acetabular stuff too. So we have a big orthotrauma service, and so people come in with acetabular fractures, and this does a good job for that too. And so we'll often add that plus a tap block sometimes, or rectus sheath block, when they're doing that incision right over the pubis to get the abdominal wall. So
I like all the different blocks. It's fun to do a block and to say, okay, that works, but how can I make it better? What else can I add? What am I missing with that coverage? I think that's the beauty of knowing anatomy.
Yeah. So at hip arthroscopy, I think PENG is great because they're jamming that trocar through the capsule, and that's what's going to hurt afterwards, and a little bit of that muscle. The muscle is going to, I think the multimodal helps a lot with that, and a little bit of muscle relaxation from the methocarbamol. And then, of course, you've talked about the arthroplasty population and how well they do with that. So I think it's nice that we do have options, and it's nice to think thoughtfully about what are the goals of care and what are the considerations that lead to us choosing block A versus block B. But it's nice to be practicing regional anesthesia in 2023 where we have these choices. We are out of time. We're over time, but I'm really appreciative of all of you for tuning in, and I want to thank Maggie so much for agreeing to be part of this webinar and offering her perspective. Big thanks to our industry partner, Pajunk Medical, for putting this together for us. And of course, a big thanks to ASRA and Heidi Border for providing the platform and the promotion and everything like that. So we will do our best to whatever questions we didn't answer. We can. This recording will be up on a YouTube video, I believe, in about 2 weeks or so. So stay tuned for that, and we'll try to do our best once that happens to answer the remaining questions that we didn't get a chance to answer in the comment section of the YouTube video, as we've done in the past. So with that, I'd like to thank you again one last time for sharing your time with us this evening, and we'll see you later. Happy blocking.